The Impact and Investment Fund is a key part of the PCN DES, and it's basically one of the only ways where networks can actually achieve additional funding by doing basically extra work. It's kind of like the PCN version of QuAF. And in this episode, we're going to outline the new criteria for 2022 and 2023, help you try and demystify it and understand what you need to do for your practice, your team, and your patients, and see if we can help get you some of those points as well. So let's get cracking in tech enhance your primary care and learning. Hello, AGP learners. And as I said in this episode, I'm Dr. Gandhi, and we're going to be looking at the IIF. This is going to be a dense episode in terms of information. We are going to go through the actual document itself. And as a result of that, go through basically everything you need to know about the Impact and Investment Fund, as much as I can tell. Now, I'll be clear, this is just my opinion. Andy's not with me today. He's off on holiday, which is awesome, and he needs to have some rest. But we're going to be going through this topic and basically trying to demystify it as best as we can. Feel free to stick your comments in the chat. Would love to know your opinions and thoughts on the various parts of this, and I'll be breaking at points to have a look at that. And this topic will be broken up into sections, and I would highly recommend at points going back and listening to the various sections and stuff. And there will be timestamps down below to help direct you to the relevant sections a little later after this episode has been published and stuff. Because there's lots to do, let's be honest on that point. So I'm going to share the document so you can actually have a look at it and stuff. But just before we do, one thing I am going to share with many of you, which is hopefully something you have seen, is the IIF summary guide. So this was produced by NHS England. I know a few people credit it to myself. Haven't done it. Be very clear on that. But it's a nice summary sheet that you can share with your local PCN team and that kind of stuff to give them an idea of some of the basic things they need to look at. So I'm just going to bring that up on screen, and there we go. So as you can see, it's this color-coded document. It's split basically into three different sections in terms of the color coding. So you've got your prevention and tackling health inequalities part here, and then you've also got this element a little bit lower on in the pink section, providing high quality care, and then the final part is sustainable NHS, which is the green part and stuff. And it's nice that they've color coded it green, isn't it? And basically, this is the summary of everything you need to do for the IAF. There is no detail in terms of how you achieve that. That's what you're about to get in this episode in terms of all the detail of what you need to know. But it's a useful document to keep at hand. What would really be nice is a proper spreadsheet that lists all this stuff out in terms of what we're going to be covering. And guess what? We'll be having that for you shortly. So myself and Andy will be creating that spreadsheet for you so you can keep a handle of that. And I think that will actually help a lot of networks a lot more significantly in terms of particularly the PCN managers and that kind of stuff. And that's one of the things that we'll be providing on our PCN CD course. So if you are interested in joining us for that, do make sure you do so. That's our PCN Plus course with Ben Gowland and also with Tara Humphreys that kicks off in a couple of weeks, actually. It starts officially on the 14th of May, I want to say. Sorry, 12th of May. Apologies on that. But sign up closes on the 5th of May. And as a result of that, you'll be able to join myself, Andy, Tara, and Ben as we basically help support new PCN CDs or established PCN CDs who want to know how to basically manage the whole PCN stuff and things. And one of the things we will be providing is this lovely spreadsheet of the IAF criteria, basically everything you need to know in one handy little spreadsheet and stuff. But effectively, we're going to get cracking now and have a look at this document. So it is a massive, and I do mean this, massive document. It is just shy of 100 pages, and there is lots and lots of detail in it. We're going to cover the basic content at the start and then go through each of the individual criteria. So do make sure you stick around for those sections and stuff. So let me just bring this down. Apologies, guys. I just need to sort out my screens because that makes it a bit easier for me to look. And there we go. So standard stuff in terms of the direction of the documents and stuff and what we're going to be looking at. And as you can see, it's split up into various different sections in terms of the structure of the IIF, the prevention, tackling health inequalities domain, the providing high quality care domain, and then the sustainable NHS domain, which is basically the inhalers part and stuff. So it does have a couple of annexes. The annexes do detail more stuff around the prevalence payments and that kind of stuff. But the first part, it basically outlines what the IIF is, why they're doing it, and from the perspective of how practice can achieve various different pieces of funding and stuff. It does outline the amount of funding. So in 1.15, it talks about the fact there's £225 million invested into the Impact Investment Fund for 22-23, and that goes up to £300 million in 23-24. So significant amounts of money. I've worked out for my particular network, which is approximately 67,000 patients, that's potentially £280,000 worth of additional funding if you achieve all the criteria. I'll be very clear, we will not be achieving all the criteria, but that's a separate issue. But that's roughly how much it would be based on the number of points. But then you do have to add in the prevalence and indicator relevant list size changes and stuff, because they have recognized that for each different indicator, one network may have a completely different list size of number of patients with those particular issues. And there's also prevalence issues in terms of the patients with those particular conditions may be completely different. And therefore, there does need to be an adjustment to make it somewhat fair. Calculating that stuff, really complicated. I'm afraid we're not going to cover that today. We have covered that in one of our previous episodes, which you're more than welcome to have a look at, which is this one, Impact Investment Fund update PCN DES, published on I can't actually remember now, sometime in October, I think it was. I'll put the links to that episode in the description down below so you can have a look at that and things. But that's a really useful one where me and Andy go through the whole details of the prevalence calculations and stuff like that, and how you can try and figure it out if you really, really want to. And then basically it talks about the various different aspects of the contract itself and what you need to be aware of and where the extraction sources are coming from. And that's really important to note, where the information sources are coming from, because there's no point trying to do all this work and store it on a system that is then not used effectively by NHS England to basically mark whether or not you have achieved those payments and stuff, because a lot of these are based on whether you have improved or changed things, and you have to have the data correct to do that. So we're going to talk about. So the next section actually summarizes the different criteria, and I'm really briefly going to cover this because the detail is actually more later down in terms of the indicators and that kind of stuff. But the prevention tackling health inequalities is split into different sections, including vaccination and IMS, and this is particularly seasonal flu vaccinations for your populations of various different cohorts, so V1, V2, and V3. As you can see there. And then there's the tackling health inequalities part, which is the learning disability reviews for those patients on your QOF registers. There's the additional part of the CVD prevention, which is a key part of and a massive focus of the IIF, sorry. And this is particularly picking up patients with hypertension, either established or new undiagnosed hypertension, as well as managing their risk factors, for example, cholesterol and that kind of stuff as well. It also includes the fairly critical at times, the DOAC parts of this, which is including the treatment of use, not necessarily the use of DOACs, but specifically the switch to Edoxaban, which has raised a lot of questions by many people, but we'll go into that in a bit more detail shortly. And then it talks about providing high quality care, part of the impact investment funds. This is the one with the most indicators in it. And there's a variety of different spread here. So there's patients referred to social prescribing, which has been a long-standing criteria of the IIF for many years. And there's a number of patients living in care homes and the care home enhanced service element of things. So this is the number of patients you're reviewing. These are the number of patients that have support plans, the number of patients have had their weekly ward round and stuff as mentioned, and the number of patients that have been admitted on an emergency basis. This is significant points in here, so important to be aware of that. Then talks about anticipatory care, so a number of admissions for ambulatory care, sensitive conditions. There's a list of that that's detailed in the document down below, which we'll come to. And then there's the percentage of patients with FIT testing for cancer, GI cancer. So this is one of the newer indicators that they've added in, so the Cancer 01 indicator. And then at Access, it talks about online consultations numbers, which is one that's been from previous years. And then the patient survey element of things as well. So we'll come to that a bit later on. There's also additional parts looking at pre-referral specialist advice. This is your choose and book advice and guidance kind of referral information that you may have heard of. Patients who've been time from booking to appointment was 2 weeks or less. That's going to be an interesting one. And number of referrals for community pharmacist consultation scheme, which has been obviously kicked off in the past few months and stuff in different areas and things. Then talks about structured medication reviews, which again has been a long-standing part of the DES and the IIF, and we covered this in detail in our previous episodes last year. The criteria doesn't seem massively different as far as I can tell but we'll go through that in a bit more detail shortly. And it has a huge focus on NSAID prescribing and GI protection, particularly use of PPIs and that kind of stuff, and we'll come to those shortly. Respiratory care then talks about the patients with inhaled corticosteroid use versus short-acting beta agonists, and then the emphasis on trying to get that as best as possible. And then the final part is sustainable NHS. And one of the things that I have recognized is the types of inhalers that patients use has a huge environmental impact. And as a result, there's an aim to switch patients, and it talks about those criteria there. So this is a section I'm going to spend a little bit more time on, and this is talking about the different types of indicators. So you've got basically qualitative and quantitative. So qualitative is basically you've done something. Apologies if I get this wrong. This is my understanding of this area, okay? But qualitative is you have to have done some sort of work towards it, but it's not necessarily based on numbers of people and things that you've done necessarily. Whereas quantitative is based on number of patients effectively targeted and treated and done something with. And then the quantitative is split into binary. So you've either done it or you haven't, and at a particular threshold or whatever. And then standard is the majority of these kind of ones, whereby there's, majority of these indicators are standard quantitative indicators and things. There's improvement indicators based on a change of ratio from a base period. And there's composite ones, which is based on the level of change based on previous performance or previous IIF criteria and stuff. So, we'll go through that in a bit more detail. It's important to know which ones are which. And it does then later, we'll come down to it, shall we? Talks about the denominators, where you get the information from and stuff, and things. Sorry, I think it's a bit later on. Okay, but at one point it does talk about the difference between quantitative and sort of composite and improvement indicators, and basically how the difference in terms of spread works. We'll get to that in a second. It does talk about exclusion exceptions, which they call personalised care adjustments. So important to use the right terminology, particularly when you're talking with NHS England themselves, because that's what they will be calling it, personalised care adjustments, and where there are some and where there aren't some. And important to note that it is relevant in some places. I think that some of the personalised care adjustments or exclusions effectively are a little bit lacking in some areas. But hey, that's what they're talking about. Yeah, so this is the achievement point section that it talked about and the difference between the two. So I'm going to go to this particular section here. So you have to achieve the section. There we are. Yeah, this is the part. So this took me a little bit of time to get my head around, to be honest, and I'm still unsure if I've got it completely clear. So for a standard or improvement qualitative indicator, it's basically based on whether or not you've got towards the upper threshold or not. And a standard one is whether you've, as far as I can understand, you've achieved the improvement based on the criteria, the levels and stuff. Whereas improvement one is how much of it you have done. So in this one, it talks about an artificial, a hypothetical one, where standard qualitative indicator worth 50 points with an upward desired direction. So you're aiming to improve things. And a lower performance threshold of 50% and an upper performance threshold of 75%. So those are the two thresholds. So if you get less than 50%, you get nothing. If you get over 75%, you've still got the maximum. You can't get anything more than that. And if there were 50 points, so that would mean there's a spread of 25 points there. So each percent is worth 2 points. And therefore, if you were to get, I can't remember, I've forgotten the numbers. Sorry, it's a bit confusing. If a person's performance is 70%, so that's, they are 20% over. So 20 times 2 is 40 points. And that's how much they would get for that particular criteria. So hopefully that's clear on standard improvements. Okay, so they would get 40 out of the 50 points because they've gone achieved that level of criteria. In composite ones, it's slightly different. So it's looking at the percentage improvement that you've had and then how much difference that makes. So, for example, consider a composite indicator with the same standard threshold. So let me just, it's a bit weird because I'm having to do this on 3 screens. So this section here, just highlighting it. Okay, So consider a composite indicator with the same standard thresholds and performance as the hypothetical example in 2.19, which is the one we just covered. Additional lower improvement threshold of 0% points, so no change from the baseline, and an upper improvement threshold of 10 percentage points, increase from baseline. The 70% achievement, the PCN would be assigned 40 points against the standard threshold. So if you just done the normal route, then 5 points are assigned for each percentage point improvement in the performance from baseline. So 50 points out of 50 points out of 10 percentage points, 0 percentage points if not. If a PCN's baseline performance is 65%, it will have assigned 25 of the 50 available achievement points, because 5 of the percentage improvement points from 65 to 70% is halfway, and 0 means done, and 10 means you've got all of them and stuff. So therefore, the PCN will actually end up earning 40 points, because that's the greatest out of the two criteria. So if it's a criteria that's got both standard improvement and composite and qualitative indicators, because in this situation they've actually earned more points through doing it the standard way, they'll get those points. Whereas if it was the opposite way around for some reason, and I can't quite understand how that would happen, where it would be the opposite way around, you get considerably more points the other way. Yeah, it is a little bit complicated, but basically we'll go through that as we go through each of the indicators and stuff. In terms of achievement points, so it talks about the fact that it's £200 per point effectively, but then you do have to add in the prevalence and adjustment payments into that and how things will be paid and things. And then monitoring, it talks about using the NHS England applications platform, that basically the dashboard they've provided. You need a specific login to get into that and see it and stuff. Um, yeah, I'm not a big fan of it, to be honest, personally. But yeah, it's the way that they're looking at the information and stuff. I think, and I'm aware there are company providers and friends of the channel, so Ardens in particular, Primary Care IT, who are providing really amazing dashboards in terms of looking at this to try and extract the data as best as possible to make it easier for you to use and stuff. And I would highly recommend having a look at their content to see how that can help you, because to be honest, it makes it so much easier looking at the way that you're doing the IIF stuff and things. Obviously, for both those companies, there is a cost that comes with that, and you're more than welcome to contact them and stuff to look into that and things. So these are the actual indicators, and we're going to be going through those now. So we're going to kick off and have a little look at how this looks. Just before we do that, I'm just going to have a quick look. So I've got a couple of comments and stuff. So got people tagging others. Christina's made a comment. Interesting that PCN receive funding for LD checks in addition to the DARES. We receive about 84% for us, but this is not a duplicate payment. So there's a difference between actually doing the work and achieving the coverage for the population, I think, and that's what the criteria is. So that, yes, you get a payment for doing the LD checks themselves for each one done, because it is an extra amount of work that you're doing for the actual patient. The whole point of this being the IIF, as far as I can understand, is it's to try and encourage practice to try and do more of those particular checks over a population basis. And that potentially means that it can be done outside of the practice. So the LD check payment goes to the practice, which is the payment for the work that they have actually done. The IIF is the incentive to try and encourage more of that work to be done, if that helps. That's my understanding. I don't think it's a duplicate payment, because the amount you get is not commensurate to the amount of work that you're actually doing. But it may help in terms of driving initiatives across your PCN to try and encourage these patients to have more of their checks, because we know that if they have their checks, they generally hopefully will have a more positive outcome in terms of their health, because we can hopefully pick up other issues and stuff. And one of the things to recognize that from the IF, there is a lot of dovetailing with various different criteria into other parts of both the DES, QOF, and other aspects of work that we do. So there is massive duplication in some senses, but it's all duplication with a view, as far as I can see, to try and drive encouraged engagement with patients, because these are challenging areas to deal with. These are not simple things that you can just do just like that kind of thing. Anyway, so let's get cracking. So we're going to talk first of all about the prevention and tackling health inequalities domain. Okay, and the first part of that is the vaccination and IMS IIF criteria. So let's have a little look at this then for you. So let me just go to that. So the vaccination IMS criteria. So this is VI01, O2, and O3. Okay. And these look at different parts. It is a standard quantitative indicator type, so you just have to do the work and try and get the achievements. In terms of VI01, it's percentage of patients aged 65 or over who have received a flu vaccination from the 1st of September to 31st of March in this financial year. For VI02, it's percentage of patients aged 18 to 64 in an at-risk group who have received a flu vax from 1st of September to 31st of March in this financial year. And then VI03 is percentage of children aged 2 or 3 on the 31st of August who have received a seasonal flu vaccination 1st of September to 31st of March in this financial year. And that's a running period from this year in terms of the way it works. And then the denominators it talks about is basically what you would expect. So the number of those who've received the vaccinations and things extracted through your GPES system, if I remember rightly. There are some exclusions. So the exclusions are those on end-of-life care, and that is it. There is no real other exclusions outside of that. In terms of personalised care adjustments, though, there are some that you can include. So patients who have declined the offer of seasonal flu vaccination, it's really important that you're coding that properly to make sure it's picked up. Situations it's not clinically appropriate to provide a seasonal flu vaccination. So I guess that could be patients. Well, sorry, can't really think of one right now. Fasting head and stuff. But yeah, I'm sure there are definitely situations, and if you do know those, put it in the chat for me because I'm having a bit of a mind blank at this point. Patient did not reply to 2 separate coded invites to receive a seasonal flu vaccination using preferred method of communication. So really important that you are, again, coding that information appropriately if a patient doesn't want it. There is a desired direction for upwards, so this means they want to improve the thresholds, and it's given the different thresholds there. So for VI1, which is your patients over 65, they're aiming for a lowest threshold of 80%. An upper threshold of 86%, and that's 40 points if you achieve that in totality. For the potentially larger cohort of 18 to 64-year-olds with the at-risk condition, then it's a 57% to 90% threshold limits with 88 points in there, so that's quite significant. And then the children ones is 45 and 82% in terms of the thresholds, and points is 14. And as I mentioned, this data is taken through the GPES extraction service. And yes, you do have to declare that it's correct and stuff once it's done. Each of these sections then gives you additional information that may be useful and they're helpful to try and do some of this kind of stuff or the evidence behind it and things. It does identify this as a supplement compared to the service payment that you get for doing the vaccination, so it's not instead of. So it is an additional payment. I think there is an element of understanding how this works with your local pharmacy teams as well, and how that information is extracted appropriately into the GPES record to make sure that that's counted. Because if that you are collaborating with pharmacy teams, or just if they are having them done in the pharmacies as well, it's still coverage for the population that counts towards this work. So it's important to note how that works and things. I think I'm frustrated with this particular one because it shows increasingly that in areas of population challenge when it comes to vaccination, we've seen this with the COVID vaccinations, that there are many populations that are still hesitant about vaccinations, and that has changed over the course of COVID and stuff. But for those deprived populations, that still remains a real challenge and stuff. This is not as much of an issue as the shifting of immunizations through QOF and that kind of stuff, because there's less of an issue in terms of catch-up mechanisms, which doesn't apply in this particular part. But it's really important to note that for seasonal flu, it's still a challenge, and how you address this, I think this needs to be a focus because it is a significant proportion of the points. It's over 100 points in totality when it comes to this particular area. So definitely have a chat with your nursing teams, with your leads in terms of immunizations and stuff. How are you going to approach this and how are you going to drive this? Because this potentially is a significant proportion of money. So you're talking about £20,000 potentially for your network plus kind of thing. Next up is tackling health inequalities, and this talks about various different aspects. So we're going to cover those in a second. The main one is one that we've briefly talked about, which is the Learning Disability Register. So patients aged 14 or over who are on the register on your QOF registers, and they should have received an annual disability health check with a health action plan. Again, this is a standard qualitative indicator for this financial year, and the denominator of those are who have received a learning disability annual health check and completed health action plan. The exclusions, there's none. Personalised care adjustments, so the exemptions kind of thing, which is slightly different. Patient refused the offer of a learning disability health check, and it's important to make sure that is coded because that extraction will come through GPES. It is a threshold limit, so 60% lower and 80% upper, and this is 36 points in total. And again, declaration and stuff, and then outlines the reasons why the health checks are really important and stuff, and why they're keen for this to happen. It does try and then look at different aspects. So it mentions about some of the stuff you should really be doing in this, so ethnicity marking and stuff, and that's relevant because that's one of the other criteria. So it can help to add into. And as I mentioned, there's a lot of blend over or crossover with these criteria and stuff that can help achieve other parts of the system as well. So that's the next one. In fact, there we go. Percentage of registered patients with a recording of ethnicity on their GP record. So this is based about trying to improve the integrity, I guess, of the data that we have. We know that particularly ethnicity had a huge impact in terms of COVID, and it was the GP data that helped with some of that. So I'm assuming that's the reason why this has been included. Again, it's a standard quantitative indicator for this financial year. The denominator is the total number of patients in your practice. And basically it's how many you achieve. There's no adjustments, and a patient recorded chosen not to state their ethnicity after having been given the opportunity to do so will be counted as a valid recording. So that's why there's no adjustments. So it still counts and things. It's an upwards trend with 81% lower threshold and 95% upper threshold. So it's quite a high level one to do, and it's 45 points. So if you're still going on the 200 points per thing and stuff, that's about £9,000 for your network. And GPES is the extraction route and stuff. This one is interesting. It shouldn't be that difficult. It's a quick exercise, and what I would highly recommend people consider is using some of the tools that you can help to do this. So, SMS-based tools that you can send to patients, or patient contact tools that allow you to do that really quickly and effectively, that integrate that within the patient record. I've definitely heard and seen some people doing some really cool things with questionnaires in TPP System 1, whereby you can send that to the patient and then they can self-fill that in, and it automatically does it for you. And those practices that use those kind of tools have had massive uptick in terms of the level of criteria, and that means that, really good way of trying to get some extra funds that you can use for future use and stuff. Talks more about the ethnicity and the codes. Really important to make sure that if you are using those questionnaires and stuff, that you're using the right codes, because it's all about coding and making sure that's correct and stuff. So next up, we're going to then talk about the CVD prevention IIF elements of things. So this is a really detailed area and stuff, and it talks about in the document why it's really important from the perspective of NHS England in terms of helping prevent deaths and that kind of stuff and things. And this does dovetail with the additional work that you have to do, which is CVD DES criteria, the outcome, sorry. And we will be covering that in a separate episode later in the next couple of weeks and stuff. So this is separate to that particular work. It does dovetail nicely with it. So it does potentially mean that if you're doing both of those elements of things, you should get more uptick in terms of the amount of patient points that you're getting. But just remember, this is separate to the CVD outcome in comparison to the work for the IIF. Okay. The difference being the CVD outcome is a contractual part of the DES, and you don't really get any additional funds for doing that, whereas this generates additional funds for practice to use to then continue doing the work and stuff. So in terms of what we have, the CVD01, a percentage of patients aged 18 or over with an elevated blood pressure reading greater than 140 over 90 milligrams of mercury and not on the QOF register. That's the key thing. So this criteria does not count your QOF register, for whom there is evidence of a clinically appropriate follow-up or confirm exclude diagnosis of hypertension. So basically, a patient that is not on the QOF register, that has a raised blood pressure reading at some point, and they need some sort of follow-up intervention, which is either, we'll come to that in a second, but basically changing treatment or diagnosis or something like that. If you've done that, you get the points. It's a standard qualitative indicator for this financial year, and the denominator is basically patients over aged 18 or over, not on the QOF register. That's what I just explained to you and things. in terms of the denominator, the number of patients you've done, it is sorry, the numerator. Where are we? So it needs a initial BP reading of less than 100. Clinically appropriate follow-up includes initial BP reading less than 140 over 90 for patients in item 1, which is the 6.6-month review that they've identified, or initial BP readings greater than 140 over 90, and then they've had either subsequent change of medication and subsequent blood pressure check less than 140 over 90, or subsequent occurrence of a ABPM, or ambulatory blood pressure monitoring, or HBPM, home blood pressure monitoring, or they've been added to the QOF register because of hypertension, or and had a referral to specialist assessments because these are younger patients and things, or addition to a QOF register and continued on therapy and stuff if they've declined therapy and things. So apologies that may have been a bit disjointed. So basically, if you've got a patient with a high blood pressure reading, they either need to have a normal blood pressure reading afterwards for this to count, or they need to have had some sort of intervention, so either treatment and therefore another check to show that that's improved, or that they've had an ABPM or a HBPM that gives you more accurate readings that can then tell you whether or not they do or don't have hypertension, and then whether they've had a diagnosis or a normal reading as a result of that, then that would count. Or a referral onwards to hypertension clinic if they are then found to have hypertension at a young age and things. In terms of exclusions, so the only exclusion is those on end-of-life care pathways. Personalised care adjustments is basically patients in the second criteria who, not followed up by the end of the financial year, will carry over into the following financial year. So if they're towards the end and stuff, and things, and if they've declined ambulatory or home blood pressure testing, and you will need to code that appropriately. But it has to be specifically ABPM or HBPM, not just coming back for normal blood pressure reading. So that doesn't count. In terms of the threshold, so it's 25% lower and 50% upper with an upward trend, 71 points in total, and the extraction is through, and the data is through GPES and stuff. So that's a pretty dense one in terms of stuff you need to be aware of and what you need to do. It then talks about why and everything else, as we've heard about, and things, and that basically this is aiming to try and reduce strokes and everything else. CVD02, percentage of registered patients on the QOF hypertension register. So it's an improvement criteria. So this is where you have to do some additional work to improve things. And basically the baseline percentage of patients on, it takes the patients on your QOF register, and there's no exclusions, there's no adjustments, and basically it's an upward trend. So this is trying to improve your criteria further. So if you get 0.6% point increase, then that's your lower threshold. If you get 1.2 percentage point increase, then that's the upper threshold. So depending on how many points you got for QOF for hypertension last year, they basically want to see an improvement. If you go through that improvement, then you get extra points. Hopefully that's pretty clear and stuff. It's based on GPES again, but it will be based on your QOF data. So that's a good way to know how you're driving with that particular one and things. Next up, CVD03, percentage of patients aged between 25 and 84 years, inclusive of the CVD risk score, Q risk 2 or 3, greater than 20%, who are currently treated with statins. So this one's a little bit interesting because the current guidance generally suggests that 10% is the criteria for prescribing statins and stuff, but they're focusing on patients with 20% or more having statins at this point. In terms of it tells you the denominators and things, but it's an indicator denominator. And exclusions are patients with established cardiovascular disease and patients at end of life. Personalized care adjustments is that the patient has declined a statin, and that needs to be coded appropriately, not just documented, coded, really important, or if it's not clinically suitable. So I'm assuming, for example, if they're intolerant or allergic to the statins and things and stuff like that. It's an upward trend with a 48% lower threshold and a 58% upper threshold, and points 31, again, extraction through GPES service and stuff. But yeah, it talks about why they want to have more people on statins and stuff. You're more than welcome to read or agree or disagree with that at that point. CVD04, percentage of patients aged 29 and under with a total cholesterol greater than 7.5, or aged 30 and over with a total cholesterol greater than 9.0 who have been referred for assessment for familial hypercholesteremia. So it talks about the wanting to try and improve the patients with these. It's a standard qualitative threshold for this financial year. And in terms of exclusion, so this is patients already with a genetically confirmed diagnosis of familial hypercholesteremia, end-of-life patients, and secondary hyperlipidemia, hypercholesteremia disorders without the subsequent history of secondary hyperlipidemia codes and stuff. Personalised care adjustment is referral for assessment for hypercholesteremia decline. So if the patients decline the referral, it's an upward trend with a 20% lower threshold and 48% upper threshold with 18 points and stuff through the GPS service. So this is an interesting one because actually I think this is not too difficult to do, and this would be an ideal project to do as a audit, potentially, for example, for your trainees, if you've got them within your network and stuff, or if you've got somebody with a specific interest in cardiovascular disease. This is a really good way of picking up numbers and being able to do the audit work across your practices. It's just a case of creating the searches, doing it, and then potentially adding in a protocol that kicks off whenever a cholesterol greater than 7.0 or 7.5 or 9.0 is documented and stuff based on the age criteria and stuff. So actually, this could be relatively easy to do, to be honest. The question is about the follow-up. And there is one thing I think really important to probably worth doing, having a chat within your ICP and letting your secondary care services know that potentially they can have an increased number of patients coming and referred to them. What will be really interesting is if your local area has a system that prevents that referrals, because we are seeing that in certain places. But according to this guidance, all these patients should be referred. So yeah, be interesting on that point, won't it? It talks a bit more about the guidance and the reasons and stuff, but I would highly recommend having a look at this, and this potentially is a really good project for some of your trainees and stuff to do. CVD05 patients on QOF atrial fibrillation register with a CHA2DS2-VASc score of 2 or more, or 1 or more in patients that are not female, who are prescribed a direct anticoagulant, a DOAC basically, or where DOAC was declined or clinically unsuitable. So this is basically trying to help prevent strokes by making sure that these patients are on DOAC treatments where clinically suitable, and that's what the CHA2DS2-VASc score indicator does. It's a standard quantitative indicator. It talks about the criteria there. The exclusions are resolved AF diagnosis in the patient's record, a subsequent CHA2DS2-VASc score less than 2 for females and less than 1 for patients that are not female, or mechanical prostatic valve replacements, because that counts as an exclusion for DOACs because you can't use them in those situations and stuff. Personalised care adjustments. This is a trickier one, so there's lots of stuff in here. So I'll read it out for you. As the indicator has multiple success criteria and evaluated sequentially, a PCA for this success criterion will simply shift the patient into a pool for evaluation against the second criteria, i.e. vitamin K, rather than removing them from the denominators altogether. Possible grounds for exception reporting these traditional senses. First, AF diagnosed in 3 months, reporting to end date. So if you've diagnosed the patient in January to March onwards in 2023, and that's potential exclusion. Oral anticoagulant clinically unsuitable, oral anticoagulant declined, a combination of PCAs applying across 1 and 2 individually and stuff. PCAs for success. So if DOAC is clinically suitable, includes recording of antiphospholipid syndrome, DOAC not indicated, plus latest recording of time and therapeutic range is greater than 65% in 6 months in reporting period, or DOAC declined. And for the success criterion 2, it's a vitamin K agonist / warfarin clinically unsuitable, vitamin K antagonist, warfarin declined, other codes to be applied and things. It's an upward trend with a 70% lower threshold and 95% upper threshold. So real drive to get patients onto this, and it's 66 points. So a reasonable amount of funding and stuff. So 1,200, is that correct? Yeah, 12,000 and stuff. And yeah, subject declaration again is the GPS service. Interesting that I think they got tired at this point of writing the GP extraction service. They've just gone to GPS, whereas all the previous ones that they had wrote out in full in the document things. It then talks about why, I think this is possibly setting up for later section and stuff. So CVD06, a number of patients are currently prescribed Edoxaban as a percentage of patients on QoF atrial fibrillation register with CHA2DS score of 2 or more, 1 or more in patients that are not female and who are currently prescribed a direct coagulant. So this is one that's been fairly controversial, to be honest, in some areas, and we'll go into that in a little bit more detail now. It is a standard quantitative indicator for this financial year, and in terms of exclusions, prevalence of AF diagnosis, a subsequent CHA2DS score of less than 2 for females and less than 1 for patients that are not female. Sorry, resolved diagnosis of AF before, not and things. It's an upward trend one with 25% lower threshold and 35% upper threshold. It's worth 66 points, and the extraction of the services through GPAs. And it does talk about in this one why they've gone down this route. So effectively, DOACs are really expensive drugs. Generally speaking, you're talking at least between 30 to 60 pounds for a month's supply of DOACs per patient. So when you multiply that, that can become a significant number cost for a patient. It is an expensive drug. So to try and standardize things, they did a procurement process that they felt was appropriate. And as a result of that, the tender went to Daiichi Sankyo as the most cost-effective DOAC presented. And that's why they're trying to suggest patients should be shifting over to this. It does talk about if patients are stable on their existing ones and don't want to change them, there are exclusions potentially to be considered at that point. However, it doesn't include this in the exclusions here as a criteria and stuff, which is slightly frustrating. So this is the section. It is important that let me highlight it for you. There we go. It is important that switching patients who are currently prescribed a different brand of DOAC to Edoxaban is done in a clinically appropriate way. As a result, is a shared decision-making conversation. To emphasize this, the indicator excludes anyone who's prescribed warfarin because DOACs are contraindicated or because they have declined to switch. So hopefully that helps you make achievements of that. So that's the CVD prevention part of things, and we're going to go on to personalized care in a second. Just before we do, I can see that we've had a comment. So there we go. UGM5 VP, so Vibor, is there acceptable or published read SNOMED codes? No, is the answer I've been able to find. I haven't been able to find a specific list, although I'm aware that lots of people are looking at this to try and help practice. And I mentioned some of the companies earlier, like Ardens and Primary Care IT, who are providing these resources directly to practices as part of their toolkits and stuff, so that they should hopefully pick out the relevant and correct codes if you're using those tools, toolkits and stuff and things. I mean, it does mention some codes throughout some of these points and stuff, so you probably can search and find them. But as far as I'm aware, I haven't been able to find a specific list anywhere. If anybody does have that list, please do share it. It'd be really appreciated. So next, we're going on to personalized care. Okay. So this area is basically, as it sounds, really personalizing care and things and what they're trying to do. So this looks at social link prescribing referrers and stuff, or whatever you're called in your local area. It's a standard quantitative criteria for this financial year. There are no exclusions, and PCA's patient has declined the referral to social prescribing service. So important to note that you need to have those codes correct on your systems. I mean, this is one of the longest standing criteria that we've had in terms of how things have been working with the PCN DES and stuff. So it's an upward trend, 1.2% lower threshold, 1.6 upper threshold, and that's I think the denominator is all registered patients. Yep, there you go. So all registered patients. So this is your total list size for all your patients in your practices in your network, and then 1.2% lower threshold, 1.6% upper threshold. For example, for my particular network, we worked out this was approximately 4 referrals a week per practice that they needed to do. It's 20 points. So there's about £4,000 if there's no adjustments, and it's extractions through the GPS service and making sure that codes are correct and stuff. And then it outlines the reasons why. And it does. There you go, Vibor. There's some particular codes for this particular one. So referral to social prescribing service, and a ridiculously long code there that you can have a look at. And it does have to be captured on the codes, otherwise it won't count. The indicator does not offer, does not count offers of social prescribing because it's necessary to know whether the offer has been accepted is therefore only counts completed referrals to social prescribing. So important to note that if you refer a patient to a social prescribing service, that doesn't count on its own. There has to be some sort of processing afterwards and engagement with the patient to see what they then wanted. So if the patient then contacts social prescriber and says, actually, I don't want that service, I would understand that they've had that referral, they've had engagement, and therefore that should count. Whether NHS England agrees with that, I don't know. Yeah. So, but it doesn't count individual contacts. So it's patients referred over, not. So if you have a patient that sees a social link worker 4 times, that doesn't count as 4 referrals, kind of thing, which kind of sounds obvious and stuff. As such, indicator does not count recording by any means of unique patient contacts by social or any other type of health, like care coordinators or health and wellbeing coaches, because there is some blend over in many areas where they're combining these services and stuff to try and make it effective and sensible for patients. So next criteria we're then looking at is the enhanced care in home IIF criteria. So there's a few criteria that looks at the care home work that we've been doing. Again, this is not new. This is stuff from previous years that's carried over, and we're going to go through that just now. So EHCH01, number of patients aged 18 or over who have recorded as living in a care home. There's a percentage of care home beds aligned to the PCN and eligible to receive network contract DES service, basically. It's a bit of a tongue twister, that one, apologies. Standard quantitative for this financial year. Denominators, number of care home beds aligned to the PCN and eligible to receive the network DES contract enhanced service. So you should hopefully be aware of that. And the numerator is number of patients 18 or over recorded as living in a care home. There are no exclusions, no personal care adjustments, upwards trend, 30% lower threshold, 85% upper threshold, 18 points in total, subject to declaration. The data source is slightly different. It's not GPES. The data source is the CQRS reporting service, and for the denominator, but the numerator is GPES. So, yeah. Interesting that. I'm not a big fan of CQRS, to be honest, but hey, additional information. So it does, the numerator of this indicator will count the number of registered patients aged 18 or over recorded living in a care home by the presence of looking for one of these 4 following SNOMED codes. So living in a nursing home, living in a residential home, living in a care home, brackets finding, and living temporarily in a care home, brackets finding. So they've added some extra codes. I think, and the 4th code has been added in previous 12 months, so they have made that potentially a bit more diverse and stuff. EHCH02, percentage of care home residents aged 18 or over who have a personalised care support plan. So again, this is another standard quantitative indicator for this financial year, and it is number of care home residents as the denominator. Numerators of the denominator number have had a personalised care plan indicated. Exclusions, patients not living in a care home at the end of the reporting period. Okay, so maybe some work to do at the end in March. Per PCA, so personalised care adjustments, patient chose not to receive the intervention. Registration with general practice aligned to a care home declined. So if they're not wanting to be part of that care home and stuff. It's an upwards trend, 80% lower threshold, 90%, 98% upper threshold, and it's 18 points. And again, information to the GPS service. This sounds quite challenging. Important to note, this massively dovetails with the next criteria, which is the patients having their weekly care home reviews. So basically, as long as you're creating those care plans with the patients when you're doing your care home reviews, this shouldn't be a problem if you're doing your care home reviews, which, to be honest, by now should be integrated. Whether it's right or wrong that general practice is being asked to do that is a separate matter. But by now, I would have hoped most networks have got this established, considering it's been going on for quite a long period of time now. In terms of the care home review, so again, standard quantitative criteria of this financial year, same denominators and in terms of the numerators, number of general practice appointments categorized as patient contact as part of a weekly care home ward round. Really important that this needs to be on your appointment books when System 1, EMIS, Vision, whatever system you're using, you need to document this there. If it's not documented there, it won't count and you won't get the points for your network, and therefore you won't get the payments for your network for that particular part of stuff that you're doing. This is separate to the £120 per care home bed that the practices receive for doing the work. But it's important to note that this is an additional criteria that can generate some additional points. So 13 points available. So that's £1,600 for your network. It's not a huge amount of money. Mean of 6 patient contacts per resident, lower threshold. 8 patient contacts per resident, upper threshold. So yeah, effectively that they're aiming that you have at least 8 contacts with each patient in your care home in totality. I don't remember that being a criteria actually, an actual number. So that's interesting. Apologies if I've missed that previously, but it looks like they have actually finally given a number of reviews that should happen with those patients over the course of the year. So that is interesting. Yeah, I missed that one. Okay, data sources, denominators, GPES service, and the numerators I mentioned is separate. Is the GPAD service, the general practice appointment data service. So yeah, just need to be doing that really. ECH EHCH04. So it talks more about the reasons for doing this and the multidisciplinary threat. I'm not going to go into that in detail. We have done an episode on care home reviews previously. You're more than welcome to check that out and stuff. There's no EHCH05 for some reason. That's gone straight to 06. I can't remember the reason why. But then this one talks about admissions in terms of a composite quantitative criteria. So basically, this is slightly different. So important to recognize this one. It is a composite quantitative one. So it's about the level of shift that you've done from previous years. This is based on the 1st of October to the 31st of March. So it's not for this first 6 months. But this is the potential time that you need to be making some of those changes to try and prevent the admissions from happening. So you've got a bit of time to do that. And basically, it is where are we? No, so there are some exclusions, and that's list of data, but there's no personal care adjustments. There's a downward trend because they want to reduce the number of admissions. Improvement, so a reduction of 0 and 0.2% is the upper threshold, and the absolute is 0.5 or 0.15 and 0.1. So basically, they want a downward trend. It's 27 points. So you know, it's about what £4,500, I want to say, off the top of my head, the network. And the denominator is GPES service, and the numerator is hospital episode statistics, number of hospital admissions experienced by patients in the denominator. Is it subject to declaration? No. PCN believes the data of the indicator is incorrect. They advise to contact the commissioners to query the discrepancies. So you need to get the information from this hospital episode statistics place. And that'll be potentially different for local areas in terms of where you're getting that source from. So important to check that. It doesn't specify types of emergencies and things. It's more about the different kind of things you need to be aware of and stuff. And it's an absolute test of the performance. Where are we? So the numerator is, here we go. Data source, patient linkage of GPES and HES APC. Patients recording the GP systems in living care homes. General episodes excludes birth. I've lost them. Apologies all. But basically, you need to use the data to figure out if there's been a reduction in the number of admissions. So what work have you done to try and support the care homes with not having to call on a patient and send them to hospital? Advanced care planning in terms of end-of-life care, I guess, is a key part of this as well. And anticipatory care in terms of preventing admissions for some of the other stuff that's going to come up in a second. So hopefully that's helpful on that particular one. More than happy to take any questions at this point. But in the meantime, we're going to crack on with anticipatory care. So this is not in terms of palliative anticipatory care that many clinicians, and me and Andy have to say this every time because we get confused with it as well, but this is about preventing admissions effectively. In terms of anticipatory care, so it talks about the standardized number of emergency admissions for specific ambulatory care sensitive conditions per registered patient. So this is a composite quantitative criteria, so it's about looking at the level of shift that you've had from previous years. This is for this financial year in totality. And it's based, the denominator is your total number of registered patients, so of your total PCN population. Numerator is age and sex standardized number of emergency admissions for specific ambulatory care sensitive conditions for the patients, and it comes to that in more detail. And it's using baseline data from the previous financial year, so 1st of April 21 to the 31st of March 22. in terms of where you get the data from, we'll come to that in a second, but it's a downwards trend reduction aimed at 0% lower threshold, 0.0001% upper threshold, and absolute elements is 0.01% and 0.008 upper threshold. It's 111 points. This is a significant chunk of the IIF. So do not minimize this. This is, if you go by £200, that's what has gone. Apologies, all £20,000 effectively, £22,000. I think I've got that right. Tell me if I've got that right, people. If you're watching and listening and stuff. Apologies, it's a bit late and I'm still fasting and a bit tired now. But this hopefully is a huge, well, it is a huge proportion of funds and stuff. The data source, again, is that hospital episode statistics, admitted patient care set data set. And the denominator is other PDS data and stuff. And that you have to contact your commissioners if you feel the information is incorrect. So what do you have to do? So they set out some conditions that they call ACSCs, which is ambulatory care sensitive conditions, and they feel that sometimes these can be prevented in primary care. And by doing effective long-term management and rapid response by general practice and stuff. Numerator is standardized by age and sex, etc. And in terms of the criteria, let's get down to it. Here we are. So you need to look for these particular filters it talks about in terms of what type of contact the patient has had. So group 1, amenable to long-term efficient care, so it's patients with asthma diagnosis, J45, J46, congestive heart failure with a diagnosis, and various criteria of why they may have been admitted, diabetes complications, COPD, hypertension and convulsions in episodes, and group 2 amenable to rapid primary care response to acute presentations, so influenza and pneumonias, pyelonephritis, cellulitis, and ENT infections. So basically it feels that those are things that can be prevented if they've got appropriate planning or support from general practice. We're really interested to know what those codes actually relate to in terms of the conditions that your local hospital trusts and stuff, in terms of what particular conditions, variations, and stuff that they are, and then potentially whether you can look at supporting that with your local teams and stuff. I think this is going to need system improvement to help support it. So this is not necessarily something just general practice can do, and you are going to need potential pathways to look at this. So potentially you could have a pyelonephritis pathway that means the patient doesn't have to go to hospital to have various interventions done. Although annoyingly, if that's how your pathway is set up and it counts as a hospital admission, you're going to be penalized, which is really frustrating in my view for those kind of things and stuff. But hey, we will see. Be interesting to know what this looks like moving forward and stuff, and love to know your opinions. And we're getting some coming through. So thank you, Christina, for correcting me. Yep. So 200 times 111, £22,200. My head's just tired and stuff. Been asked, please remind us the difference between reduction and absolute. I'm not 100% sure, but I think there's different criteria because they're composite ones. You have the different criteria of whether you have an element of reduction, or whether you've done absolute total numbers of reduction versus that. So it's based on either your previous criteria and stuff. So I'll be honest, I'm not 100% sure, Vibor. So I'll try and find out for you in that one. So next we're going to talk about cancer care QoF. So this is an element of how you can help improve cancer care. We're approximately 3/4 of the way through, people. I know this is a long session. Apologies for the information dense elements of this, but if you have found this useful, I really would appreciate if you could leave me a like at this point, because it just lets me know that you're actually still with me and things, and this is useful information for you. Deliberately, we've done an information dense episode for you to try and help all the networks and stuff out there and things. In terms of cancer care, so this is one of the newer criteria that has just been added in for this financial year. So percentage of lower gastrointestinal 2-week wait fast track referrals that have been accompanied by a fit test with the result recorded either in 7 days leading up to the referral or in the 14 days after the referral. So evidence talks about the reasons for using fit tests and stuff and why it can be relevant and things. And this is with a view to reducing demand of colonoscopy tests and stuff. and a proportion of lower GI referrals that do not pick up any pathology. It's a standard quantitative criteria for this financial year. The denominator is the number of lower GI 2-week wait fast track referrals for suspected cancer, and the denominator is the number of referrals accompanied by a fit test when the results recorded either in 7 days up to lead in the referral or 14 days after referral. There is no exclusions. PCA is provision of fecal immunized basic fit test declined without subsequent recording of a fit test afterwards. So understanding how that's been documented. It's an upward trend with 40% lower threshold, 80% upper threshold, and 22 points, about just over £4,000 for your network on extraction through the GPES service. So this is an interesting one because this has caused a bit of for consultation across the general practice spectrum and stuff. Encouraging a patient to uptake fit, make sure the patient is aware of the importance of completing a fit. It gives you some information, and they're working with secondary care about the referral process system and including it in the forms and stuff. So in our local area, we've been using fits for a while, and I think they have some benefit in the certain situations. I think the challenge is for those populations which doing a fit test is quite difficult. So whether it's down to language, so do you need to create resources to help support your patients who don't speak English how to do the test, because they kind of have to do it themselves. It's a stool sample test that they have to do and do properly and things. And the emphasis is on the timing. So are there tools that you can use in general practice to help do this? So things like off the top of my head, the Accurix, not Florries, Pathways, I think it's called, or something. They're a tool that basically allows you to automate text messages to remind patients to send a message to the patient so they can do the thing that they need to do, kind of thing. But is there an element of timing this based around the referrals? Because there is a tight time window of when you need to have sent the fit test. So there's 7 days before the referral, which if you've done a referral, if you're contemplating doing it, so doing the fit test first and then doing the 2-week wait referral once you've had the results, and make sure you've done that referral within 7 days of having the result, or alternately doing the referral and then make sure the patient has returned the sample back within 2 weeks, which is not a small amount of time. Interestingly, in our area, you can't give the patient a fit test. It has to be sent to them. So there is an element of waiting and education in terms of making sure the patient does that appropriately and stuff. But what do you think? Do you think fit testing is appropriate, or should it just be referral and off you go? I'd be keen to know what people think in that particular one. So we've had some comments. Christina's mentioned, do you think in time QoF will cease being with value being moved towards IIF? IIF feels like QoF. Well, Christina, to be honest, I call it the QoF of the network. So yeah, probably. And we are seeing a greater shift towards it. It does mention that the value of this is going to go up next year. What happens after 24, we don't know, because we don't know what's happening specifically with the DES and everything else at that point, but who knows? And Vibor, thank you for that, sharing your thoughts while also fasting. Yeah, I'm definitely flailing at this point now, but we're going to crack on because we're almost there. So next it talks about the Access IIF. This one is going to be fun, so make sure you stick around for this because we're going to talk about it right now. And what is the Access IIF? Well, it's an interesting part of it, shall we say. So ACC02, number of online consultations submissions received by PCN. So this was here in previous years, and it was one of the ones that was carried over in terms of because payments had already been made before IIF got paused due to the Omicron variants and stuff, which was outlined in the letter and stuff. It's a binary quantitative one, so you've either done it or haven't. And it's from the 1st of April to the 31st of March of this financial year. Total number of registered patients and the numerator is the number of online consultation submissions received by the PCM. There is no exclusions, no personal care adjustments. It is an upward trend, and the threshold is 0.26%. It's a single threshold. So as I mentioned, you either do it or you don't. 18 points, so 3,600 odd pounds for the network. Extraction service is through GPES or the online consultation, virtual consultation, extended collection service, or whatever it's called, basically from your online consultation service provider. And basically, this is 5 consultations per 1,000 registered patients per week that needs to be done across your network area. And if you've done that, you will get the points. Simple as that. So I think Practices in areas where they've moved to an online consultation model as their point of entry for the door will have absolutely no problems doing this. I think practices that haven't done that, they will potentially have real challenges in terms of doing this, and there's an element of making sure that you are looking at how that works and stuff, because you need to have those level of numbers and stuff per week effectively to do it. You may have situations where some practices do it and some practices don't, and that's enough to hit the criteria, because don't forget it's based on your network population level, not just on your practice population. It'd be interesting to have those discussions and stuff, but potentially could be really easy to get this funding, could be really difficult to get this funding for some places and stuff. So it'd be interesting to know what that looks like and moves like and stuff. But the criteria is quite low, to be honest. 5 out of per 1,000 per population, so it's not a huge amount, to be honest. By the 31st of March, make use of the GP patient survey for results in the practice to identify patient groups experiencing inequalities and their experience of access to general practice, develop, publish, and implement a plan to improve the patient experience and access for these patient groups, taking into account demographic information, including levels of deprivation. So this is about trying to improve access. It's a qualitative criteria for this financial year. There's no denominators, no exclusions, no prevalence stuff and things, and no thresholds either. It is 48 points, so it's a significant proportion of funding that can be happened, and it's confirmation through the CQRS. So let's have a little look at it. So it's an indicator asked by 31st of March. PCN should make use of the 2012, 2021, 2022 general practice patient survey, so your survey from last year, to identify patient groups experience inequalities in their experience of access to general practice and develop a plan to improve the access for these patients. In particular, they're asking you to focus on question 16, why do patients want an appointment, did not receive one? Question 19, patients who avoided making an appointment. Question 20, patients' overall experience of making an appointment. And question 30, overall experience. PCNs are strongly encouraged to make use of other data and sources and evidence when identifying groups and stuff, which provide information and demographics, and should also consider using Core 20+5, which is aimed at supporting the reduction of health inequality both at national system level. It should be a SMART document, so the SMART principles, so specific, measurable, actionable, something and timed. I always forget what the R is. If you do know what the R is, let me know in the chat. Prepared by PCN, input from all members of the practices submitted to CCG, which sets out the patient groups that are being targeted, a plan for improving access for these patient groups, how that improvement will be measured, and then this plan will be published by the CCG. PCN should then consider developing and sharing their plans with local interested partners, for example, the constituent practice, PPGs, and HealthWatch, etc. and stuff. So it's a chunk of work. It's a chunk of audit work that will pay for the work that you've done it. So potentially, if you can have members of your team do this as part of your structured plans and stuff, and it massively dovetails with the QoF/QI for GP access elements, which we covered in one of our earlier episodes a couple of weeks ago. So do feel free to go and have a look at that, because that will give you more information as to what those particular criteria are and how they do massively dovetail with this particular criteria. Interesting to know that QoF/QI also will get you payment if you do that. So that was 37 QoF points in total. So 27 for doing the work and 10 for sharing it across your network. So twinning that with this would be really awesome. It does require separate audit survey work to be done, because the QoF/QI is based off this financial year, whereas this one is looking at your previous GP survey work. But combining those, if possible, would absolutely be a sensible option for you to consider and things. So that may help to basically make life a little bit easier and stuff. ACC05 by 31st of March, make use of the patient. Sorry, that's the same one. Sorry, ACC07 is then number of pre-referrals, specialist advice requests made across 12 specialities, identified accelerated delivery of first outpatient attendance. This is basically a choose and book advice and guidance. It's a standard quantitative criteria for this financial year. The denominator. So again, this is a really useful one to potentially look at getting some searches created within your referral teams and stuff that you're doing. But across 12 specialities, identified accelerated delivery: cardiology, dermatology, gastroenterology, gynecology, neurology, urology, pediatrics, endocrinology, hematology, rheumatology, respiratory, and ENT. Total number of process referrals to specialist advice requests across the 12 specialties identified for accelerated delivery. So it says over your number of registered patients. There's no prevalence adjustments and stuff for this particular criteria. There's no exclusions. There's no PCAs. It's an upward trend. Threshold is 0.06%, lower threshold, and upper threshold is 0.19%. 44 points. So yeah, fair chunk of money, about £8,000, £80,000. Sorry. Yeah, £80,000. And it's the numerator is from the SEROC, so the System Elective Recovery Outpatient Collection System. I have no idea what that is. So worth finding out from your ICP and hospital trust what the hell that is, or from your CCGs. Worth asking your locality teams and stuff. And the denominator output is the HES, is the SUS again. Not great on knowing what those are, to be honest, but I'm assuming that your system will be able to provide you with that information. You can challenge it, so potentially worth practice keeping a record themselves of the types of referral that they're doing, and this hopefully shouldn't be too much of an issue. A quick spreadsheet of number of referrals you've done and how many of those are advice and guidance. If you want, we can even provide you with a quick little spreadsheet that does that for you. Again, that will be provided as part of the course on the PCN Clinical Directors course. And you're welcome to join us. PCN Plus bit.ly/PCN Plus in capitals, where we'll be providing that resource for you. And it basically talks about why they want to do this, and it's long and short of it's reducing outpatient appointments and stuff. There has been a lot of talk about how advice and guidance works and the sensible portions of that and stuff, and whether or not the transfer risk, how that works. We're not going to get into that debate here. Me and Andy have talked about that previously in some of our episodes and stuff. But important to note these key things in terms of it's a good chunk of money for your potential network and stuff and things. So there's lots of information about the data and stuff that you can look into, and I'm not going to go into that in detail at this point. Right, ACC08, percentage of patients whose time from booking to appointment was 2 weeks or less. So this is about improving access to general practice, and massive shift in terms of this one. I think this is going to be the one that most networks are going to really struggle with doing in some way, shape or form. Standard qualitative criteria for this financial year: number of appointments delivered by the general practice under the 8 national appointment criteria. So it's based, I'm assuming, off your GPAB, but we'll come to that in a second. Denominator: the number of patients for which time to booking appointment was 2 weeks, 14 days or less. In terms of there's no exclusions, there's no primary personalised care adjustments. It's an upward trend, 85% lower threshold, 90% upper threshold, and 0.71. So a significant proportion of money. We're talking £140,000 potentially, plus. Again, GPAD data, subject declaration. Yes. Improving access to general practice is one of the most significant challenges. Yep, we absolutely know that. Apparently, there's going to be 50 million extra appointments. Well, we're probably already doing a fair chunk of that as it is. And there's obviously reiterated their promise of 6,000 new GPs and 26,000 new clinicians through the DES and stuff and things. Yeah, well, you can take that as you want to and stuff. The GPAD, so again, feel free to check out our previous episode on GPAD. I'll stick that in the description a little bit later on. So the appointment categories that this is going to matter. ACC08 only includes appointments mapped to national categories in the former group: general practice acute, general consultation acute, general consultation routine, unplanned clinical activity, clinical triage, walk-in, home visit, care home visit, care home related encounter, but does not fit into any of the criteria. Any appointment mapped to one of the above 8 national criteria in the scope of ACC08, irrespective of the mode and method by which the appointment was delivered, e.g. face-to-face, whether the appointment was recorded as attended or booked or not, did not attend. Are general practice waiting times still relevant in post-pandemic report? Okay, so let's have a look at that. Apologies, I haven't looked at this one in great detail beforehand. They're measuring the waiting times. So this is the key part, I'm assuming. Measuring true waiting times, reducing appointment exception appointment. There are 2 reasons why time from booking to appointment might not capture true waiting time for an appointment in general practice, which might be defined as different. Some patient may explicitly request an appointment or on a defined future date. Yeah. GP may come back and see me in 4 weeks, for example. Patients may struggle to make contact with their practice at the first time. Asking for telephone may be engaged, meaning that if they request their first available appointment, blah, blah, blah. To address the first point, okay, thresholds. Apologies, guys, I haven't read this one in more detail, so I'm just going to catch up with it now. 20, thresholds for ACC08 have been set at a relatively modest level. The lower threshold, 85%, corresponds to 20 percentile of the current national performance, while the upper threshold, 90%, corresponds to 50 percentile median performance. There may ample room for PCNs to continue to book appointments more than 2 weeks in advance where there's no appointment. If the patient requests an appointment in the future, if there is a clinically indicated interval between appointments, patients should continue to make appointments more than 2 weeks in advance and should continue to book patients into these appointments. See, the reason why I'm slightly confused is I don't know how they're going to evaluate this. So if a patient makes contact, how are you going to know that they've had that appointment within 2 weeks of that contact? I'm assuming this is actually just asking us to move to a 2-week cycle of booking appointments. I'd really like if someone could tell me what they think of this particular one because I'm a bit confused in terms of the criteria, to be honest. I think as long as you're using those criteria in the appointments, you will have some uptick in terms of what that looks like and fulfills. But that's a little bit of a confusing one, to be honest. So yeah, we will see. ACC09. Anyway, let's move on to a different one. Number of referrals to the community pharmacist consultation service per registered patient. So this is the new service that's been set up over the past few months, designed to try and support general practice. How supportive that is varies, I think, at different places in different areas. I know, for example, for our network population, none of the pharmacies have actually agreed to do this. So that's been a bit of a challenge, although I think one of them is just about to start doing so. So hopefully that will mean we have a service, because actually we've not even had the option of referring patients to these services in our population. I do know of some places where they found it to be a really effective resource and really effective collaboration between general practice and pharmacist services and benefit for the patients as well. In terms of the denominator, total number of registered patients, the numerator, number of referrals made to the CPCS service. It's an upwards trend. Threshold is 0.034%. It's a single threshold and it's 27 points. GPES service is the extraction point, and it's requiring 2 codes, potentially referral to community pharmacy consultation service, and same but with refused at the end of it and things. And it's just basically counting the number of referrals you have to do. The activity level has been set at a minimal level as a purpose to demonstrate the practices and the PCNs of a functioning referral community system. As such, IIF is based on a single activity threshold for CPCS. This threshold has been set at a modest level corresponding to 0.65 CPCS per referrals per 1,000 patients. So in 10,000 patient population area, so a typical practice size, you would be expected to do 66.5 CPCS referrals a week. So, for example, for my practice, for my network population, that would be 6.5 times 6, 30. So it's approximately 40 referrals a week would need to be happening across my network population and stuff. So hopefully that's a helpful guide there for you in that one. And that is that section done. Right, we've got a few more sections to go, people. I know you've been with me for a while. This is a long episode. Apologies on that, and thank you for sticking with me. So thank you to, I'm going to shout out your names. So thank you to Emma. The administration burden on the fit test could cause people to slip through the net if there's no robust systems in place. Absolutely agree with you. That's why you need a robust systems in place. Thank you to Vibor, who's still with us, commenting on about realistic and stuff, and Christina. 2-week wait for appointments. Really important to check your appointment mapping and stuff. Yep, absolutely agree with that. It's not going to be. That's a weird one, I must admit. Anyway, last couple of sections. So we've got structured medication reviews, IIF. So I'm not going to go into this one in great detail. We're going to whistle through this one because actually the structured medication reviews hopefully is a part that many of you have already been doing because it's been a long-standing part of the QOF. Just to outline the points and payments and stuff. So percentage of patients at risk of harm in medication areas have received a standard structured medication review. So it's a standard quantitative one. Your denominators are those criteria that many of you probably should be aware of in terms of patients aged over 65 prescribed an NSAID and not on a PPI. Patients over 18 with a history of peptic ulcer disease prescribed an oral NSAID Patients over 18 with a history of peptic ulceration on antiplatelet, patients 18 or over prescribed oral anticoagulants. Basically, it's a massive list of things, but you should hopefully be already having your pharmacist doing this, because this has been a long-standing one. It's an upwards trend. Just to clarify the criteria, it's thresholds 44% lower threshold, 62% upper threshold, 0.26 GPES extraction service. This is secondary to the next one, which is percentage of patients with severe frailty who've received a structured medication review. So number of patients with severe frailty is your denominator, and then obviously how many have had their review. Exclusions, none, but PCAs is patients receiving end-of-life care, and the patient has chosen not to have the intervention done. It's an upwards trend of 44% lower threshold, 62% upper threshold, 9 points. So less points because, to be honest, this should be an established part of general practice by now to some degree with the network staff and things and the pharmacists. General practice extraction service. Moving on to SMR010C, patients have addictive medicines who received a structured medication review. So this is standard quantitative again. Talks about patients on addictive medications like gabapentinoids, benzodiazepines, Z drugs, oral or transdermal opiates, other than your basically your weak opiates and stuff. Interestingly, tramadol is counted as a strong opiate according to this, as far as I can tell. So worth being aware of that. Doesn't include heroin substitutes though, and patients with who receive more than 120 milligrams of morphine a day. In terms of exclusions, so it talks about the exclusions if they're on low opiate doses, and if they're on cancer care review and things. And the adjustments are patients receiving end-of-life care, or patients chose not to receive the intervention. It's an upwards trend of lower threshold 44% and 62% upper threshold, again 9 points. GPES extraction service. Important to note, this one massively dovetails with your DFM QoF QI work that you will need to do in terms of looking at this workload. So that will hopefully help manage some of this for you. SMR101D, percentage of patients in care home that have had a structured medication review. So hopefully that should be self-explanatory. 44% lower threshold, 62% upper threshold, 9 points again, GPES extraction service. SMR02, patients aged 18 or over prescribed both NSAIDs and oral anticoagulant in the last 3 months, who in the 3 months to reporting period had no longer prescribed an NSAID or PPI. So basically, it's gastroprotection and stuff, thinking standard quantitative this financial year. Got the denominators in terms of the criteria. So no enumerators of the denominator, the patients who in the 3 months to the reporting end year were either no longer on an NSAID or prescribed a PPI. So either if they're on a long-term NSAID, not to be on it or to have a PPI protection. 85% lower threshold, 90% upper threshold, upward trend, 4 points, GPES service. Trying to get through this one as quick as possible. So percentage of patients 65 or over with an NSAID not on an oral anticoagulant in the last 3 months, who in the 3 months before the end of the reporting period no longer on an NSAID or are prescribed a PPI. First of so standard quantitative again. Upwards trend, 85% lower threshold, 90% upper threshold, 4 points. So that's 800 quid for a standard network size, GPES extraction service and stuff. Again, these should be embedded already into your network. SMR OTC, patients 18 or over, prescribe both anticoagulants and antiplatelets, and again, reviews. Should be on a PPI ideally. If not, 75% lower threshold, 90% upper threshold, upward trend, 4 points, GPES service. Next, we're on patients 18 or over prescribed aspirin or other antiplatelets medications who in the last 3 months have been stopped or prescribed a PPI. Again, this is 75% lower threshold, 90% upper threshold, 4 points, GPES extraction service. Patient prescribed DOAC who have received a renal function test in their weight and criteria, and so it's basically confirming the dose of the DOAC's correct because it is based on EGFR and stuff. Upwards trend, 50% lower threshold, 75% upper threshold, 13 points, so a much higher proportion of funding and stuff, and GPES service. And that's that particular criteria. So that's definitely one for the focus with your pharmacists in your practice and your pharmacy technicians. Hopefully, this should already be embedded, and that should be stuff that your network should be able to achieve relatively easy and stuff. Maybe it's just having some of those searches in place, so particularly the one for the DOAC one and stuff, and potentially reminders to help on, when you're prescribing NSAIDs and stuff to prescribe a PPI, that kind of thing. Respiratory area is what we're going on to next, and then we're on to the final one after that. So the respiratory area is about looking at inhaled corticosteroid treatments and stuff. Again, this can be driven a lot by your network pharmacist, I would imagine. But the percentage of patients on QOF asthma register, so not only your pharmacist, but also absolutely your practice nurses, your asthma nurses, and that kind of stuff, and your team that focuses on this. But effectively, percentage of patients on QOF asthma register received 3 or more inhaled corticosteroids, inclusive of ICS/LABA, over the previous 12 months. So ideally, that's how many they feel they should be having. Um, So where are we? A standard quantitative criteria. It's based off your QOF register for asthma, and the denominator is those who receive 3 or more ICS inhalers. Um, and no exclusions, but personalized care adjustments as patient added to the QOF in the last 9 months of the financial year. Not clinically suitable as measured by presence of inhaled corticosteroid not indicated, recording mild asthma without subsequent intervention of moderate or severe asthma, fewer than 3 SABA prescriptions in the same month, save 12-month period, or 4 for those under the age 18. 71% lower threshold, 90% upper threshold, 31 points, so a reasonable amount of funding to do, and definitely work that your asthma teams can focus on. Talked about the improved reasons for having good inhaled treatments, and in terms of the corticosteroid treatment for asthma. Remember, this is for asthma, not for COPD. But then the second one is percentage of patients on asthma register who received 6 or more short-acting beta agonist inhalers over the previous 12 months. Again, standard quantitative over this financial year. And it's a downward trend because they want to reduce this. They want to basically mean, as you would understand, have patients use less inhaled short-acting beta agonists, so less salbutamol, basically. 25% lower threshold, 15% upper threshold, so you get more points if you have less patients. 22 points, so again, reasonable amount. That's about £4,000 for your network. GPES service extraction data, and it gives you the reasons why there. I think that's a really useful one because we know that excess use of salbutamol can have an impact. Potentially, it's worth considering moving patients over to the FMART treatments, as I know some of the guidance is suggesting moving towards that. So, final part, you'd be glad to know that we're almost there. Just before we get to that, I'm going to go see what comments we've got. So, Christina's thanking for the time. You're more than welcome. Hope it's been useful and stuff. And we're going to talk now about the sustainability elements within the IIF. So effectively, this is again is about inhaled corticosteroid treatment, effectively, and inhalers. But basically, meter dose inhalers, prescription, that percentage of them non-salbutamol. Sorry, I'll start again. Metered dose inhaler prescriptions as a percentage of all non-salbutamol inhaler prescriptions issued to general practice in patients 12 or over. So basically, people with asthma is your denominator. So number of non-salbutamol inhaler prescriptions issued to the patients aged 12 or over, and the numerator of the denominator, the number of meter dose inhalers prescriptions. It is a downward trend, so they want us to move away from MDIs. There's no so the exclusions are prescriptions to patients whom dry powder inhaler not indicated has been applied. So if patients don't like or can't tolerate the dry powder inhalers, then to move add that code in is really important. PCA none, but note the dry powder inhaler will function similarly to a not clinically suitable PCA. The thresholds are 44% lower threshold, 35% upper threshold, with 27 points available, the GPES service. And it gives the reasons why they want to move away from that there. And it's basically about environmental impact in terms of MDIs versus dry powders. And then mean carbon emissions per salbutamol inhaler prescribed or after 1st of October. So it talks about the reasons for it there. It's about environmental protection. Standard quantitative, number of salbutamol inhalers prescribed as your denominator, total carbon emissions from all inhalers in the denominator. Number of patients prescribed salbutamol inhalers is the prevalence numerator. There's no exclusions, no primary personalized care adjustments and stuff, and it's a downward trend. And the aim is going from 22.1 kilograms as your lower threshold, or 18.0 kilograms CO2 as your upper threshold. 44 points, massive amount. So this is a system change element. So you're talking nearly £80,000 for a standard network size. And it's about switching the types of inhalers and number of inhalers and stuff that you're prescribing across your footprint and stuff. It does give you the amount of carbon dioxide in particular inhalers, so less in certain ones. So looking at this, your Ventolin Aculen inhaler is 0.58 grams per inhaler compared to your salbutamol CFC breath actuated one, which is 11.97, and your generic salbutamol, wow, CFC inhaler is 25.24 grams of. Geez, they are significantly more. Similar to the Ventolin Evo inhaler with 100 microgram one, which is 28 grams. So you can have significant changes by switching your inhaler brands and stuff in terms of the types of inhalers you may be using and things. Wow. Interesting to know that, isn't it? I haven't seen the numbers before, but that is a massive shift. 20, potentially almost 30 times less the Ventolin Aculen inhaler versus the Ventolin Evo inhaler in terms of CO2 emissions. Interesting. Anyway, it'll be based on what your local area is suggesting and agreeing and how you would want to plan. Obviously, important to note that what's sensible for the patient is really important and how they use it, because you don't want to then end up causing clinical issues in terms of changes and stuff from that point. And then mentioned in the annexes, it talks to us about how to work out the prevalence adjustments and the reasons for doing that versus the list adjustments, which is separate criteria, and the indicator standardization formula is there as well if you want to have a look at it in addition. So hopefully you found that really useful and effective. I apologize, it's been a massively long episode. I think it's one of the longest episodes we've ever done, an hour and a half going, but hopefully that will give you a really good summary of the IIF criteria and the information you need to know. As I mentioned, that there will be timestamps added shortly after this episode is finished, so you'll be able to go back and look at relevant sections. So feel free to share that with other people so they can see it and be aware of things and stuff. The link to the document is already in the show notes on the YouTube channel, and it will be on the podcast if you're listening to this on the podcast. So I've had a question from Sophisticated Steph. Great name, I love that. Will you attach the link to this document? So yes, it's already there in the if you just click on the down arrow on the YouTube, or if you're listening on the podcast, you just need to click down to have a look at that and stuff, and that will give you the information from there. Mavi Josh, will GP practice clinicians or dispensing pharmacists be expected to educate patients on the technique for different inhalers? Kinda. Patients don't know how to use them, they're not going to use them. Important to note, there are some really good video-based resources out there from Asthma UK and various other places in terms of how to use specific inhalers. Highly recommend sharing those at the time. That's an additional resource. As many of you know, I'm a big advocate of using video to enhance the educational aspects of patients and stuff, and have some videos, but not one about inhaler techniques, because Asthma UK do it far better than I do and stuff. But really important, I think, to understand that global warming is a world level issue, and these are some of the simple things, and the amount, as we just seen there, the amount of CO2 difference that can have an impact is significant in terms of the inhaled treatments and things. If you do want more information, like I said, you're more than welcome to contact us and stuff. We'll try and find out some stuff as we go along. But a lot of the links will be attached, as well as links to the other episodes that we cover and have talked about in this episode. Additionally, as I mentioned earlier, if you do want to join myself, Andy, Tara, and Ben in our clinical directors course, so for new or for established PCN clinical directors, feel free to log on and join us for that. It is almost full, so I think we've only got about 4 or 5 places left. So PCN Plus, so that's the name of the course, and to register is bit.ly/PCN Plus in capitals. That will take you to the sign up page. The course closes in terms of sign up on the 5th of May, and in terms of starts on the 12th of May. It is a massive thing that we're doing, and we're hopeful it's going to be really useful to our PCN CDs, and you will be getting additional resources throughout that course that we won't be publishing in other places and stuff as well as access to me, Ben, Tara, and Andy in terms of the course development and things, and content and things. Hopefully, if you do have any other questions, let me know. As I said, more than happy to try and tackle those. And do check out this episode that's going to give you more information about the various aspects that we're talking about. Andy and myself are going to be going through the PCN DES outcomes in the next few weeks, tackling those and giving you more details to what you need to know, as well as stuff like network hours and other content as well. And as usual, we're here to help tech enhance your primary care and learning. We'll catch you next episode.